Hello, my name is Bonnie Moon, and this is a case presentation of RUTIs for NURU 673, Practicum in Common and Acute Problems in Family Across the Lifespan Care at the University of Massachusetts Global. In this case, the patient complained of having recurrent urinary tract infections, or UTIs. UTIs account for almost 25% of all bacterial infections in women. Over half of all women experience UTIs in their lifetime. The most common pathogen that causes UTIs is E. coli. Usually, the same pathogen causes recurrent UTIs, are mainly caused by reinfection of the same pathogen. Frequent sexual intercourse is one of the biggest risk factors. The patient in this case is a 70-year-old Caucasian female who was in her normal state of health until 3 weeks ago when she developed fatigue and a burning sensation while urinating. The patient reports that this is her second diagnosed urinary tract infection within 12 months. She describes her urine as yellow and concentrated. While urinating, she rates her burning sensation as an 8 out of 10 pain and a 0 out of 10 at rest. Her burning sensation is worse with dehydration and minimally relieved after completing her 5-day course of Bactrim prescribed from urgent care. Her fatigue subsided a few days after initiating her course of antibiotics. She denies sick, contacts, fever, and recent travel. The patient's past medical history includes urinary tract infections with unknown complicated UTI history, dyslipidemia, glaucoma, hypothyroidism, and type 2 diabetes mellitus that is non-insulin dependent. Her surgical history includes a cholecystectomy in 2011 and Mohs surgery of squamous cell carcinoma on her right thigh. Her obstetrical and gynecology history includes 1 pregnancy and 1 baby with no miscarriages or abortions. She is currently postmenopausal. The patient's family history includes paternal history of diabetes mellitus type 2 and deceased at 74 years old to pneumonia with no history of cancer. Maternal history includes hypertension and deceased at 80 years old to cerebral vascular accident with no history of cancer. For the subjective review of systems, the constitutional pertinent negatives that the patient reports is no fever, no chills, no sweats, no recent weight changes, no recent weight loss in appetite, no recent unexplained weight gain, no weakness in legs. The patient denies headache and migraines. A pertinent positive is a reported fatigue score of 7 out of 10. For the integumentary system, the patient denies lesions, rashes, vesicles, and wounds. In the musculoskeletal system, the patient denies back pain, muscle cramping, neck pain, joint pain, muscle weakness, stiffness, and myalgia. For the eyes, ears, nose, and throat, the patient denies blurry vision, double vision, eye pain, eye irritation, and eye discharge. She denies having a decrease in visual acuity and photophobia. The patient denies earache, denies tinnitus, denies decreased hearing, denies dysphagia, epistaxis, sore throat, hoarseness, sinus congestion, rhinorrhea, and ear discharge. There are no pertinent positives for EENT. Within the cardiovascular system, the patient denies chest pain, syncope, presyncope, palpitations, irregular heart rate, swelling, and dyspnea. For the respiratory system, the patient denies dry cough, productive cough, shortness of breath, wheezing, and hemoptysis. For the gastrointestinal system, the patient denies nausea, vomiting, diarrhea, constipation, a change in bowel habits, abdominal pain, hematochezia, melena, jaundice, heartburn, incontinence, bloating, anal pruritus, and hemorrhoids. There are no pertinent positives within these systems. The pertinent negatives for the genitourinary system include no reports of cloudy urine, urinary retention, urgency, polyuria, incontinence, hematuria, and flank pain. She denies vaginal itching and a change in vaginal discharge, including yellowish green, white, and or thick discharge. The pertinent positives are dysuria and vaginal dryness. Objectively, my physical exam findings are as follows. The vital signs are a height of 64 inches with a weight of 235.6 pounds, yielding a morbidly obese BMI of 40.4. Temperature is 97.2. BP is 141/83. Heart rate is 78 and respiratory rate is 18. The patient's general appearance is overnourished, clean, and well-dressed appearance. She is alert and oriented times 4, calm, shows no signs of distress, and is cooperative. When examining her head, her facial features are symmetric, head is normal cephalic, head is atraumatic, and hair and scalp are normal. Physical exam findings for eyes, ears, nose, and throat are as follows. The patient's vision and eyelids are normal. There is no xanthelasma. The conjunctiva are pink. Pupils are equal, round, reacted to light, and accommodate. The extraocular muscles are intact. The sclera are normal. The fundi are benign, and cataracts are absent. The tonsils are not enlarged. There is good dentition, gums, and palate condition. Her ear canals are clear. The tympanic membranes, hearing, nasal septum, and turbinates are normal. Sinuses are non-tender. Her neck is supple. She has normal jugular venous pressure, normal carotid upstroke without brutes. The thyroid gland and lymph nodes are not enlarged. The patient exhibits normal respiratory effort. Intercostal retractions are absent. There is no use of accessory muscles noted. Normal diaphragmatic movement is present and lungs are clear bilaterally to auscultation and percussion. Cardiovascular system physical exam findings show that the point of maximal impulse is normal. There are no heaves, lifts, or thrills present. The heart rhythm is regular and the rate is normal. There is no rubs or murmurs noted. The blood pressure is equal in both arms. There is no significant orthostatic changes noted. The patient's abdomen is symmetric and non-distended. Her bowel sounds are normal active in all 4 quadrants upon auscultation, and there is abdominal tenderness upon palpation in the right lower quadrant and left lower quadrant. No masses or organomegaly were noted, and no brutes were present. After examination on her back, the range of motion is normal. There is no kyphosis noted, and the straight leg test is negative. The patient's extremities show that there are no joint abnormalities present, no clubbing, no cyanosis, no petechiae, no ankle edema present bilaterally, and no varicosities of lower extremities noted. The femoral, popliteal, and pedal pulses are normal. Assessment findings of the neurologic system show that cranial nerves 2 through 7 are intact. Her muscle tone is normal. She has no focal, sensory, or motor defects. The deep tendon reflexes are symmetric, and her gait is normal. Psychiatric examination note that her judgment, insight, and memory are intact. Her mood and affect are appropriate. She has no suicidal and homicidal ideations. Important laboratory diagnostics include a CBC white blood cell count of 8 and a urinalysis that was cloudy with large occult blood, positive nitrites, moderate leukocyte esterase, 50 plus white blood cells, 0 to 2 red blood cells, 10 to 20 squamous epithelial cells, and few bacteria. The diagnosis is a recurrent urinary tract infection. Urinalysis reflex results after a short course of Bactrim reveals positive nitrites, large occult blood, moderate leukocyte esterase, and white blood cells of more than 50. Associated symptoms are dysuria, fatigue, and lower abdominal tenderness. These are common symptoms with UTI in the past per the patient. Her differentials include pyelonephritis, interstitial cystitis, and vaginitis. In complicated cases, the FDA recommends levofloxacin 250 mg orally daily for 3 days. Give oral solution for 1 hour before or 2 hours after meals. Fluoroquinolones are associated with tendinitis, tendon rupture, peripheral neuropathy, and central nervous system effects that may occur together. Tendinitis, tendon rupture that may occur during treatment or months after treatment is discontinued. Risk further increases in patients over 60 years old. Premarin vaginal estrogens, conjugated vaginal 0.5 grams, to be applied vaginally 3 times per week. In postmenopausal women with symptomatic UTIs, vaginal estrogen therapy should be considered as a preventative measure. Pyridium, 200 milligrams orally 3 times a day as needed for dysuria. Take this medication after meals. It causes urine discoloration of red-orange color. Cranberry supplement, 36 milligrams, proanthocyanidins, PO daily. Avoid taking warm baths. Avoid acidic foods like coffee, citrus, tomato products, chocolate, alcohol, artificial sweeteners, carbonated beverages. Increase water intake to achieve dilute urine. Wear cotton underwear. Limit thong use. For hygiene, wipe from front to back and limit or do not use feminine deodorant sprays. Return to office and follow up if symptoms recur or do not resolve. Retention or flank pain, nausea, vomiting, fever over 100.4. If any of those occur, call the office immediately for a follow-up appointment. Follow up within 1 month with a repeat urinary analysis. Clinical practice guidelines from the American Academy of Family Physicians recommends in the management of recurrent uncomplicated urinary tract infections to verify that symptoms are similar at each episode and confirmed with a urinary analysis. They also recommend to void after intercourse, avoid spermicide, and to use topical estrogen in postmenopausal women, and also the use of prophylactic antibiotics in either daily at a low dose or postcoital. And this concludes my presentation on recurrent urinary tract infections and management. Here are my references. Thank you.